Thank you.
I am a late entrant to this instruction course, and thanks to Malika that I am here. I'll just briefly, we all know that endogenous endophthalmitis is not that common as exogenous endophthalmitis is there. But then, it comes all of a sudden, one fine morning you find that there is a congestion in the eye, there is a photophobia, pain, swelling and all that. And then you find that the vision is less, and then you report to the doctor. Basically, it is an intraocular infection from hematogenous transmission. And many a times it is bilateral, maybe 15 to 25% of cases, and it can occur apparently in healthy individual. As I told you, just one fine morning you find that you are having this problem, and maybe many a time there is a very sick patients, which will be talking later, and maybe many a time misdiagnosed. Most majority of the cases as uveitis, conjunctivitis, glaucoma, or cellulitis. And the initial symptoms are very important because based on this is the prognosis of the patient, which is pain, swelling of the lid, and congestion in the eye. Most common organism is the Candida, and Aspergillus has a poor prognosis than Candida, as it may lead to vascular occlusions. One of the very important feature is the white on red appearance in the conjunctiva, and early signs of this endogenous endophthalmitis is vision, decrease in the vision, there is a lid swelling, and there is a blepharospasm. These three things are there, and with the decrease in the vision, they should alert the ophthalmologist that a possibility of endogenous endophthalmitis is there. Many a times one will be able to find the track, maybe in the form of suture abscess, or there is a wound dehiscence, or there is a vitreous touch, or there is a penetration, ocular penetration is there. Beside this, fibrinous exudate in the pupillary area, and a non-dilating pupil, and fibrinous membrane formation over the intraocular lens. These are the important points one has to remember. In order of severity, the picture in the fundus in the posterior segment, it starts with a decreased or absence of the fundal glow, then there is an inflammation of the vitreous, there is a vitreous exudate, there is a retinitis, there is a retinal hemorrhage, there is a retinal necrosis, periphyllum and papillitis. This is the course of events in the posterior segment. Who are the individuals who are prone to develop endogenous endophthalmitis? Those who have long-term IV catheter is there, intravenous hyperalimentation, very frequently there could be drug abusers are there. Then we have immunocompromised states, HIV, diabetes mellitus, malignancy, and also aged people who are like 70, 75, 80 years. And then history of abdominal or pelvic surgery earlier, and the sources basically are from the liver, from the lungs, and from the heart, and of course if there is a septicemia and the meningitis. If you go on to the microbiology, it is culture positive in 64% of cases, and 66% of these are positive for Candida, and then there are other gram-negative organisms are there. Common organisms involved is Candida and Aspergillus, Staphylococcus aureus, gram-negative organisms. Many times there is Streptococcus is also involved. The sequence of event is the risk factors are there, though I have already enumerated them, and then there is a heterogeneous dissemination of the organism, colonization in the choroid, and which spreads to the retina and comes in the vitreous, and then whole lot of eye is involved. There is a classification. Basically, it comes from the choroid, choroidal changes without extension in the vitreous cavity, stage 1. Stage 2 is fungal mass penetrating through the inner limiting membrane and budding into the vitreous cavity. Stage 3 is vitreous opacity resulting blood fundus. Stage 4, vitreous opacity plus retinal detachment is there when it comes as a hematogenous source. And these are the important things one has to remember. We have to keep in mind that what are the findings in the systemic workup which lead us to that this patient is an immunocompromised patient or any other kind of existing infection is there. The management of this endogenous bacterial endophthalmitis is basically very high dose of systemic antibiotic. We say that the meningitic dose of antibiotic should be given for endogenous bacterial endophthalmitis, and intravitreal injections in the form of ceftazidimine and vancomycin could be given. And when The media is very hazy. One can do the ultrasonography and find a lot of exudates are there in the vitreous cavity. One can go for a vitrectomy and intravitreal antibiotic. This is a case report from Malika's series. This is a dental root infection, vitreous type culture. RNA microchip examination showed E. coli. This patient has systemic augmentin, intravenous augmentin, ceftazidime and metrogyl for 2 weeks, followed by oral ofloxacin. Both high intravitreal antibiotic were also administered, but this patient did not respond to it, and ultimately vitrectomy had to be done with intravitreal antibiotics, and the resolution was seen in over 3 weeks. After 6 weeks, visual acuity was 20/20. So the moral of the story is that at one point of time, early vitrectomy helps in endogenous bacterial endophthalmitis. These are suspected fungal endogenous endophthalmitis. The intravitreal antifungal agent is voriconazole could be given, and systemic antifungal agents are also given. There is a definite role of vitrectomy in this fungal endogenous endophthalmitis. This is a case where voriconazole 200 milligram BD in 2 weeks, followed by oral voriconazole 200 milligram BD for 6 months were given. We have to keep the treatment for a very longer time because of the fungus persisting for a very long time, and then vitrectomy for intravitreal amphotericin B and voriconazole were performed, and further 2 intravitreal injections were given, combinations, and resolution was seen at 8 weeks. This is a post-vitrectomy. This is also post-vitrectomy. This is 2 weeks later, and this is at 8 weeks, visual acuity was 20/20. So what the take-home message is, intravenous antibiotic plus metrogyl plus oral antibiotic should be given for a very long time in endogenous bacteria endophthalmitis, and vitrectomy should be done as early as possible along with the systemic antibiotics, and resolution is normally achieved between 2 to 4 weeks after vitrectomy. The take-home message for endogenous fungal endophthalmitis is that antifungals of different groups work synergistically, and fungal endophthalmitis needs aggressive local therapy that may be prolonged up to 8 months in the cases which was shown, and systemic antifungal may be indicated for a period of 1 year. Nowadays, we have third generation of fluoroquinolones are there, like levofloxacin 500 to 750 milligram OD or ofloxacin. They work very well, and they may alleviate the need for intravitreal antibiotics. And they also act synergistically with antifungal agents so that you can combine when there is a endogenous fungal endophthalmitis is there. Thank you very much.